Good morning, and welcome to the 2020 Johns Hopkins University School of Medicine first ever virtual reunion. I'm Diane Orlinsky, president of the Johns Hopkins Medical and Surgical Association. Even though we're not using the traditional reunion format, I'm grateful that we can connect virtually during these very difficult, disruptive times, and I'm delighted to have so many of you join us here this morning, even though I can't see any of you. Today, we will hear from three institutional leaders about COVID-19's impact on the Johns Hopkins Health System and the School of Medicine. There will be a Q&A session for all speakers at the end of the program. Please submit your questions using the Q&A button at the bottom of your screen. We'll address as many as we can in the time allotted. I now ask Dean Paul Rothman to provide an update on Johns Hopkins Medicine and the health system.
Good morning. I'm hoping you can hear me and see me. My name is Paul Rothman, and I am the Dean of the Medical Faculty and the CEO here at Johns Hopkins Medicine. First of all, I want to thank all of you for joining us here today for this virtual reunion. We are so sorry that you can't be here in person, but we really appreciate your engagement and for you coming on to the Zoom today. I'm sure many of you are Zooming a lot, so hopefully we can have a good session today and talk about some important issues. For many of you, as is true here at Hopkins Medicine, COVID has really transformed this institution. And before I begin, what has, I think, been the most remarkable thing is just the courage and sacrifice of our frontline staff here. You have many people working long hours in very difficult situations. And that is from the house officers and attendings and nurses to the environmental service workers, the security workers, just have all pitched in very difficult circumstances. And I'm sure that's true for many of you and for the hospitals you're working at. So I think what I want to begin with is publicly just thanking all of you who are putting your lives on the line and sacrificing for our patients. This is truly, hopefully, a once-in-a-lifetime pandemic that we're living through. So we've had a lot of challenges here, as I'm sure many of you had in your practices, but I think I'm so proud of the response we've had at Hopkins Medicine and Johns Hopkins University. Our website is quoted almost daily. Every time I listen to the news, they talk about the Hopkins data as being a non-partial and the one truth that people believe in, and that's wonderful. When we think about what we've had to do here, we've really transformed our operation. We had influx fairly early on. We had a command center that over our 5 Mid-Atlantic hospitals, 2 here in Baltimore, 2 in Washington, D.C., and 1 in Howard County. It oversees all those hospitals. We very quickly downsized our routine care and our elective surgeries. We sent thousands of people home to work from home virtually. We greatly decreased our research activities. Only essential personnel were allowed to keep research going, except for COVID research. And we've seen many of our faculty change their direction of research and trying to help attack COVID and find either cures or treatments or help with diagnosis or try to fundamentally understand the virus. We sent our students home the first years and we asked them to work online, and Roy will talk more about that. And our 3rd and 4th year students who were still seeing patients, we took them off the wards to help preserve our protective equipment and those supplies. We did a great collaboration with the University of Maryland, where we together set up a field hospital at the Baltimore Convention Center, which could have had up to 250 patients in it. And those were for patients, really patients who are post-acute with COVID, to get them so we could decompress our hospital systems and sort of be this transition state for those, especially those who couldn't go home or go back to a nursing home, to take care of them in interim. As we look down, Lisa Maragakis, who speak a little bit later, will talk in more depth. We've seen about 1,600 patients at Hopkins Medicine hospitals. We currently have just under 200. We've had between 200 and 300 patients for much of this, but those numbers have been going down over the past couple of weeks. One of the things that we did early on that was terrific is Ralph Rubin, our pathology department, developed their own test very, very early on. So we were able to test patients before or at the same time commercial tests were available, and have tested over 38,000 patients with 5,000 positives. The other thing we did, I think, that helped us was that very early on, actually in January, as we saw issues in China, we started a supply chain initiative to ensure we'd have protective equipment for all our folks. One of the things that was terrific was we actually have a warehouse, so we were able to store PPE very early on, and at least Ishi helped on that. And to date, we've had the supplies we've needed and have not had a ration, and everyone who needs PPE in any one of our hospitals has been able to get it. Lisa will talk more about a lot of the clinical operations there. Our clinicians have done a terrific job caring for our patients, and as we, over the past week or two, we've noticed as our virus have gone down and the state has allowed us, we are starting to think about how we're going to reopen our clinical operations. We started just now 2 weeks ago with our ambulatory surgical centers, getting patients there. They're at about 50% capacity now, following a very strict CDC guidelines. We are now again trying to ramp up all of our operations over the next several weeks as the state and others allow us to do that. As well, I talk about our rising fourth-year students started to come back and go on the wards just this past week, seeing non-COVID patients in the hospital, especially those who need sub-internships. One of the things that we're very proud of is our research during this time. We're presently running, I think, between 8 and 10 clinical trials, some of the national trials such as remdesivir. Convalescent plasma serum was initiated here in a randomized controlled trial. We have several other therapeutics. We ramped up a data platform so that all the data from all our hospitals, and now we are collaborating with 3 other academic medical centers to share all of our data. So our data scientists can try to use that data to better care for our patients. And we have, I think, a very robust biospecimen collection to help our researchers try to understand this disease. We've done a couple of things we're really proud of. Taking care of our workers and employees. So we've noticed that some of them are just working so hard they don't have time to go to the grocery store or to cook a meal. So we've been able to provide meals for some of them. In addition, we are providing some meals for people here in East Baltimore who are having a hard time with it because of lost jobs, unemployment. Over 2,000 families have been taken care of through our food efforts here in East Baltimore. Finally, we've done a lot to help the community. We're doing testing for nursing homes. We have a team that if a nursing home feels they need help, will go out and take care of them. And maybe Lisa will touch on that a little bit. This has been a time that I could not have been more proud of Johns Hopkins University Health System and Johns Hopkins Medicine. The folks have stepped up in ways that I could only have imagined. And we are just blessed to have the talent we have here at Johns Hopkins Medicine. So now I'd like to turn it over to Roy Ziegelstein, who is the Vice Dean for Education. Roy?
Thank you, Paul. And thanks to everyone for attending this virtual reunion. I'm sorry I don't have the opportunity to meet you in person as we normally would. And I hope that one day I'll have the chance to meet many of you and speak to you by phone or communicate by email. I'm Roy Ziegelstein. Vice Dean for Education, and I'm going to be focusing my comments on the education component of Johns Hopkins. My office oversees academic programs for a total of about 4,000 learners in the School of Medicine, medical students, PhD and master's students, dual degree students like MD, PhD, residents, clinical fellows, and postdoctoral research fellows. These 4,000 students and trainees and the faculty who lead their programs and teach them are some of the most amazing people in the world. And I think you know that because you were among them. They're committed to the Hopkins tradition of excellence, innovation, creativity, and advancing human health, much as you are. As individuals imbued with the Hopkins culture and spirit, I hope that my comments allow you to share my sense of deep pride in them and in our school. The pandemic has actually affected the experience of these trainees in very different ways. For example, the laboratory work of most of our 2,000 or so PhD and master's students and most of our postdoctoral research fellows has been interrupted now for 2.5 months. They've had to do what they can to pursue their studies, stay connected with their lab remotely, having remote lab meetings. And in truth, they're worried about how they're going to progress toward their degree. They've had to interrupt crucial experiments. They're worried about the job market after graduation. And for some, they're even worried about their visa status. Yet we hope to bring them back to the laboratory sometime very soon. On the other hand, our residents and clinical fellows have been very much on the front lines caring for COVID-19 patients with all the commitment and caring and also anxiety and stress that comes with that, worrying that they may be carrying risk home to their spouses, partners, friends, children, or older relatives. I'm sure those are some of the concerns that you have. Many of our residents and fellows have interrupted their usual training and refocused or have been redeployed in areas of the hospital and in types of care that they did not intend to be part of during their residency or fellowship. And all of that has been because of their overwhelming dedication to our patients. I often find myself thinking about them, and again, I have this overwhelming sense of pride because I believe that they represent the best of our great institution throughout history. I've been asked many times during my years as Vice Dean whether today's trainees are as dedicated and committed to the profession and to their patients as trainees a generation or more ago. There can be no doubt that they are. Finally, our medical students. As we all know, COVID-19 hit our country and hit Maryland and Baltimore in the springtime. And for medical students, spring is a time of transition. Our first years were preparing to move on to second year and marking that transition with the white coat ceremony, which we celebrate at the end of first year. That ceremony had to be canceled and it will be rescheduled when it can safely take place in person. Our second year students, they were excited about transitioning to the wards and that had to be put on hold. Our third years were eagerly contemplating their specialty and residency choice. They were thinking about what sub-internships to schedule, which residency programs to apply to. They were thinking about away electives, and they were preparing to interview for residency next year. Well, those sub-internships and in-person clinical electives had to be put on hold. Actually, all away electives have been canceled for the entire academic year, pretty much across the country. And all residency interviews will now be virtual. No travel, no visits. Very different from when we all applied. Our fourth year students, they were excited about match day, preparing for their final capstone course. And of course, they were really excited about the milestone celebration of convocation at the Meyerhoff. Match day became virtual. Envelopes and champagne were not enjoyed together, but separately by Zoom. The capstone course, that was done remotely, and convocation was done virtually as well. And now, after about 2.5 months away from direct patient care, as Paul told you earlier, our students are beginning a phased return. They began that just this week to clinical care. And yet, the ingenuity and creativity that have been ushered in so quickly by COVID-19 has been absolutely unbelievable. I have to read a quote for you. "To have lived through a revolution, to have seen a new birth of science, a new dispensation of health, reorganized medical schools, remodeled hospitals, a new outlook for humanity is not given to every generation. Well, it turns out that Osler said that in 1913, and I believe that we are living through a revolution right now. Faculty here at Hopkins converted much of the curriculum to really high quality online material with live interactive sessions within weeks and sometimes within days. For example, our neurosciences faculty created an online brain dissection video, and it made me realize for the first time, I actually never really learned about it in medical school. I used a 2D atlas. I never really understood the flow of CSF. Who actually knew what formed the floor and roof of the lateral ventricle? I memorized it, but I never really could envision it. And where the heck is the splenium of the corpus callosum? Well, now I know. I watched the video. It was unbelievable. It won't surprise you as alumni to learn that this material was created with the same high quality and the same Hopkins tradition that your education was created. In fact, our students say that they often learned better and were more satisfied than in previous years. I think it's because our faculty now really had to seriously, critically think about what and how they teach. Our faculty created 29 virtual electives for our students, again in short order, that were incredibly high quality. Our faculty also created telemedicine opportunities for our students, including a telecritical care elective in which students are actually able to go on virtual rounds with ICU patients. Now, that actually caught the attention of the AAMC, the Association for American Medical Colleges. They featured that in one of their stories last month on medical education. In particular, they featured Lee Goodell, a faculty member in anesthesiology and critical care medicine. And again, I'm going to read a quote. They noted, quote, before Lee Goodell treats patients in the surgical intensive care unit at Johns Hopkins, he dons gloves, a protective gown, and a negative air pressure hood that helps dispel pathogens. These days, he also puts on another essential piece of equipment, headgear that holds a cell phone to his forehead so remote students can continue learning during the COVID-19 pandemic. Thanks to the contraption, students can tune in via their computers or iPads as Hopkins educators narrate the unfolding medical process, and they can shoot over any key questions through a live online chat function, unquote. The bottom line is, I really believe that when all this is done and we review this part of history in medical education, we're going to conclude that the COVID era has seen a revolution in education at Johns Hopkins, much as it did 100 years ago. And this revolution here, I think, would make Abraham Flexner, Osler, Halstead, Welch, Kelly, and all of you incredibly proud about what our faculty, students, residents, and fellows have done. I'll now turn things over to Lisa Maragakis, Senior Director of Infection Prevention at Johns Hopkins, who's played an unbelievably crucial role in advising and guiding all of us, in fact, guiding the country during this pandemic. Lisa?
Thank you so much, Roy. And I would like to thank Dean Rothman and Diane and the organizers for inviting me to join this event today. It's such an honor to speak with you. And I am sorry that we can't be in person, but very happy to be able to be together and talk about this historic response at Johns Hopkins Medicine. Before I begin, I thought I would just say a few words about a memory that I have of the first time that I set foot on Broadway and looked up at the dome as a first-year medical student and felt the incredible mixture of honor and excitement and awesome sense of responsibility of joining the family of Johns Hopkins Medicine and hoping that I could live up in some small way to the history of this institution. And I think we are all acutely aware of the history of our institution. As Paul and Roy have said, Johns Hopkins Medicine has played an enormous role in the past, and most notably in the 1918 response to the flu pandemic. And a sense of history really ties us today, I think, to that time and the role of our organization in responding to a healthcare crisis and leading really around the world. And I hope that wherever you are today, whether you are here in Baltimore at Johns Hopkins or wherever you are around the world, and whatever role you are playing in the COVID-19 response, that you feel connected to us and to this sense of history. And as Roy said, to our continued efforts to strive for excellence in patient care, in teaching the next generation of medical leaders, and in advancing the science now of SARS-CoV-2 and the care of patients. And there's so many questions to be answered and so much great work going on. So I think that ties us all together on this day of your reunion. So I'll begin my remarks by talking about the response and how early it began at Johns Hopkins Medicine. And I would be remiss if I didn't say that we have had preparedness planning in place for years for pandemic respiratory viruses. And so we were able in very early January to build upon our plans and our preparedness activities and get a jump start and an early beginning to our response here at Johns Hopkins Medicine. We dusted off the pandemic response plan and realized that it needed much more detail and some modifications to respond to the COVID-19 situation. But we began in earnest in mid-January to obtain personal protective equipment and particularly respiratory protection, recognizing that the concern about an airborne transmission of this virus meant that we would need a large supply of respirators, and in particular, reusable respirators, anticipating that the disposable kind could be in short supply. And this has served us well in a supply chain that has been very unsteady, uncertain, and quite frankly, predatory in the marketplace, and that has made it difficult at times to have a reliable supply of the very basic things that we would need. It's one of the most remarkable things in this pandemic, I think, to be faced with such a critical infectious disease threat and to realize that you don't have some of the very basic things like personal protective equipment, disinfectants, and hand sanitizer. And that has led to innovation and partnerships across manufacturing and across our own organization and our colleagues at the Applied Physics Lab, for instance, who have helped to manufacture face shields. We set up an enormous manufacturing effort at our warehouse to make face shields for every employee at Johns Hopkins Medicine, and to provide them with a personal protective pack that we called P3, so that every employee at Johns Hopkins has at the ready what we used to call a fanny pack, but a belt pack that contains a mask and supplies and instructions for reusing our mask and our N95, which is something that would have been unthinkable in pre-pandemic times, but we are doing it safely and providing face shields, as I said. And I know that our employees have greatly appreciated this effort, particularly recognizing the supply chain challenges and the fact that we are operating under these difficult circumstances, but really placing their health and safety at the forefront. As Dean Rothman said, we have performed over 33,000 tests here at Johns Hopkins Medicine. Many of these are for our patients in our own institutions throughout the health system, and also helping other institutions in the Baltimore and DC area, and community investigations and cooperation with the health department. We have over 5,000 of those patients who have tested positive and have admitted 1,700 patients to one of our 6 hospitals across the health system. As Dean Rothman said, currently we have fewer than 200, just under 200 patients in our hospitals in the health system. And at the height, this was 300. And about a quarter of the patients at any given time are on mechanical ventilation. So we have managed to not be overrun by the types of surge that we have seen in New York City and other places around the world. But I will not lie to you. I will say that it has strained our capacity, and we did this really by shifting, stopping elective surgeries and shifting our non-COVID bed capacity over to the care of patients who are affected with COVID-19. And this worked well, and we were able to respond and care for these patients. A bigger challenge is now upon us, as many of the patients without COVID-19, with other medical conditions, are returning to our hospitals. And we are realizing that for the long term, we will be caring for both COVID and non-COVID populations of patients. And this is the challenge for the days ahead. I wanted to say a word about Airborne Precautions, because it was really at the foundation of our strategy for patient placement and the protection of our patients and our healthcare workers. Very early on, the Centers for Disease Control and Prevention recommended airborne precautions and the use of respirators when caring for patients under investigation or known to have COVID-19. And this is much different than influenza, for which we usually use droplet precautions or a regular medical mask and eye protection. I spoke with colleagues at the Centers for Disease Control and Prevention in late January and asked them in earnest to please share with us if they anticipated changing these guidelines. And I was told no. And from that point on, we centered our plan around airborne protection and the creation of negative pressure respiratory isolation units in each of our hospitals. And this is no small task. And we have relied upon our facilities colleagues who have done a remarkable job and really miraculous job of creating changes in our air handling systems and building anterooms and enclosures and spaces so that our clinicians care for patients in these respiratory isolation units. And it's just a remarkable transformation of our physical space and an extra layer of protection in addition to the personal protective equipment. We cohort the patients together in these respiratory isolation units, and additionally developed a health system-wide strategy to cohort the patients first in the Johns Hopkins Hospital, transferring those who tested positive in our affiliated hospitals to the East Baltimore campus. And this was a deliberate strategy, as I said, co-locating the patients in those respiratory isolation units as we bought time to build respiratory isolation units at each of our hospitals. And so now each of our hospitals cares for patients in those locations and keeps 2 separate streams of patients, those with and those without the disease. I'm the Senior Director for Infection Prevention, and I could not be more proud of our teams of infection prevention epidemiologists, infectious disease physicians, microbiologists, and data analysts, with whom I work every day to develop guidance and policies and procedures, and answering everyone's questions and conducting training for the safety of our patients and our employees. And it really has been a Herculean task, and one that I feel like they have done extremely well. Paul alluded to the microbiology lab and our pathology colleagues who were remarkable and in their early development of a test, a in-house test for reverse transcriptase PCR to detect the virus. And this was in the very early days when the CDC test had not yet been distributed, and everyone was sending samples to the CDC for testing. That took days to get the results. And then, as we all know, the first set of tests that the CDC distributed to the state health departments unfortunately did not work as anticipated. And in those days where everyone was clamoring for the ability to test, our microbiology lab, through a leadership of Dr. Heba Mustafa and Dr. Karen Carroll and Dr. Ralph Prubran, came forward with an in-house test. And since that time, they have really done an enormous amount of work validating various platforms, because personal protective equipment is not the only thing affected by the supply chain troubles that I alluded to earlier. But the platforms and the reagents and the supplies needed to test patients for COVID-19 or SARS-CoV-2 were also often in short supply. And to date, they have validated in the microbiology lab at least 8 different platforms. And they use them in concert, in coordination, as a patchwork to be able to provide now 2,400 tests a day. And this forms a large part of the testing that is available in our state. So we are very grateful to them, and really would have been blind without the work that they did to help us with this. Occupational Health Services has also been deeply involved in the response, and I am very, very happy to tell you that we feel that we have been extremely successful in protecting our employees. We have, of course, had employees who have tested positive for SARS-CoV-2, and some of whom have been hospitalized, and some of whom have required critical care services. The overwhelming majority of these employees and frontline health workers who have contracted the disease did so, however, through community or household contacts rather than in our hospital itself. We have universal masking, limiting of visitors, and a very comprehensive program for social distancing that consistently reminds everyone that when we're not providing direct patient care, we must maintain social distance between each other. And sometimes this is particularly hard in break rooms and other areas, but everyone has adapted so well to these changes, and it's helping keep everyone safe. Paul alluded to the fact that we have redesigned healthcare delivery during our COVID-19 response, really from stem to stern. And our ambulatory colleagues led the way with development of a comprehensive program to provide by telemedicine answers to so many questions that patients had, to answer the questions of the worried well, to provide care and advice to the mildly ill, and to direct those who needed to be tested to newly set up testing tents that were deployed throughout our health system to provide the testing capacity and safely obtain the samples for testing for COVID-19. Much of our healthcare delivery, especially in the ambulatory setting, has been transitioned to telemedicine. And it's one of the things that we think may be a lasting change to healthcare after the pandemic. In addition, we have tried to limit the number of patients that need to come to the emergency department so that we can concentrate on the patients who most need care in that setting. And I've mentioned the facilities and inpatient changes. I talked about the physical changes that we did to create the respiratory isolation units, but I'd like to say a few words about the redeployment of our staff. And I echo Dean Rothman's words about being so grateful and so proud of all of the Johns Hopkins colleagues who have stepped forward, and many of whom were actually retrained in order to take on roles as respiratory therapists, to step up from their skill levels from intermediate care to ICU level care, and all of our faculty and trainees who answered the call and came to care for these patients when we had the maximum number of patients in our COVID units. And as has been mentioned, we have also partnered beyond our healthcare system and Johns Hopkins Medicine. And we are a part of the community, and it is a sad fact that many of the patients who are affected with this disease reside in nursing homes or are members of very vulnerable communities, either because of their housing situations, their underlying medical conditions, because they are experiencing homelessness, or they are in prison. And we have a very dynamic public-private partnership. And Johns Hopkins Medicine has worked very closely with our colleagues at University of Maryland and with public health officials in the city and the state to provide outreach and teams, who, in particular, to the long-term care facilities and to our Latino populations around Baltimore City, have been able to provide all kinds of services, including testing, education on infection prevention, personal protective equipment, and other services so that we can serve these communities and help keep everyone safe. Looking ahead, I think the million-dollar question is, what is going to happen next? As Paul said in his opening comments, the numbers in the Baltimore region have started to come down over the last couple of weeks, and we are very hopeful that this trend will continue. Models tell us, however, that we may, and actually are probably likely, to have a second surge of patients, and we know that as the weather has warmed and reopening has begun, that social distancing has become a challenge in many settings, and so we are preparing plans to take care of a second surge. And we are also preparing for the long haul, recognizing that this virus is likely with us for a number of months, if not years. That's a grim reality that is a major challenge. And I believe that we are up to this challenge and that we will develop plans to meet the challenge. I also think there's many opportunities embedded in this crisis. And we have already begun conversations about those opportunities and ways in which we can make sure that patient care and research and teaching are even better after the pandemic than they were before. So again, I would like to thank you for the opportunity to be here today and to share some of this with you. And I'd like to turn it over to your questions so that we can have a Q&A session. Diane?
Thank you so much, Lisa, Roy, and Dean Rothman. That was incredible. So I'm going to talk fast so we can get as many questions in as possible. So our first question is, how many faculty and staff at Johns Hopkins Medicine have been infected with COVID-19 and how are they recovering? Probably Lisa, that's a good question for you.
Sure. So I unfortunately don't have the exact number here, but I think it is somewhere around 450. Paul, correct me if I'm wrong, but the last number that I saw was around 450. We have had, unfortunately, one death of an employee. As I said earlier in my remarks, the overwhelming majority, including the one employee who did die, did obtain the virus likely from community or household contacts. So I think that's an important thing to emphasize. Like any member of the community, our own employees and healthcare workers have potential exposures in their own homes and in the community.
So actually along those lines, here's another question to Lisa or anybody who wants to answer. What are your recommendations to us as physicians to minimize the risk of bringing COVID home to our families after we come home from work?
It's a great question and one that we get often. So, you know, I think the first thing is taking all of the precautions while you are at work. So wearing the personal protective equipment, making sure that you do hand hygiene. I mentioned in my remarks the challenge of social distancing. I actually think that our employees and all of you are safer while caring for patients with COVID-19. If you follow all of the personal protective equipment and infection prevention precautions, you're probably safer there than you are in the break room, where we do take off our mask and sit with our colleagues, or when we're in public spaces. So number one is maintaining social distancing, and then I would say hand hygiene. Many people do choose to do other layers of ritual when you get home, in terms of changing clothes before you have close contact with loved ones and other things.
I would just add, Lisa, one of the things we did early on was set up a hotel program for all our healthcare workers, those who were directly caring for COVID patients. If they didn't feel comfortable going home because they might have someone at home who either is elderly or compromised, that they could stay overnight in hotels while they cared for COVID patients.
Thank you. I want to remind the attendees that you can ask your questions with the Q&A option at the bottom of the screen. Let's see. Oh, Roy, would it be possible to make the teaching videos that you talked about be made available online to alumni? That is a great question.
That is a great question. First of all, I'm delighted that that alumni want to learn about the brain, and share in my pleasure at doing so after more than 30 years. Let me look into that, and I will get back to our Alumni Association about whether and how. It's hard for me to answer at the moment, but I will do my best to see if that's possible.
Thank you. Next question, and probably for everyone. Have you all observed a mental health impact on providers or researchers? And what kind of support mechanisms are there that we can help people?
So maybe I'll begin, and Lisa, you could kick in. So our psychiatry department has some expertise in thinking through the stress and of crisis management, and they describe a curve where you first have this heroic and phase where people really get the adrenaline going and just do what they have to take care of patients, and this honeymoon after that, and then a rapid drop off in what they call a disillusionment phase, where that initial adrenaline rush is going, and you see that this is not going to go away in a day or a week or a month. And then you have slow recovery and reconstruction after that. And so we've done a couple of things to try to, and we're seeing it. We see people who are very stressed, a little burned out in that disillusionment part of the curve. We started about a year and a half ago what's called the Office of Wellbeing. It's Johns Hopkins Medicine, which is for staff of physicians. And they've had a series of outreaches trying to support people. We have what's called a RISE team that Albert Wu runs. It goes to units and talks to people and find out who might need additional help. We have what's called a COVID response clinic, or Covert, run by one of our psychiatrists that people can be referred to if they have issues. There's also a daily session called mindfulness-based stress reduction session online with a psychologist that people can zoom into. So we have a series of things. We do know that people are feeling very stressed by this, and we're trying to give them many support mechanisms to help them. Lisa, did I miss anything else that we're doing?
I think you covered it. And I just would echo that it's such an important question, and one that we have taken very seriously for all of the resources that Paul outlined. And I think that people really appreciate it and are using it.
If I could also mention a couple of other things. There's something called the Comm App, which is, as the name would imply, an app that can help people with relaxation and meditation. I believe it's the #1 or 2 most popular of these type apps across the country, and it's available to everybody at Hopkins for free. All individuals who are employees or students. Our students also have available to them, students and trainees, something called Silver Cloud, which is a digital mental health platform. And very recently, they have available to them something called Timely MD, which is a 24/7 talk program that allows them to speak with a licensed mental health professional. I mentioned these, and you might say that seems that digital environment seems very different from what we're used to in terms of high touch provision of mental health services and so forth. But please remember that for about 2.5 months, many of our trainees have not even been in Maryland. And so we wanted to be able to reach out to them in this way. The other is that it's very easy to access these features, I'll say, without having to make an appointment and come in and so forth. So they've been very popular, and I think they've been very helpful.
That's so helpful. Thank you. I have another question here. What is the projected financial impact of the COVID-19 efforts on the institution? Dean Rothman.
Oh, that's a little complex. You know, so we have 4 hospitals within the Maryland system. For those who don't know, the Maryland has a very unique hospital reimbursement system where we have capitated revenues called a GBR system. And so for our Maryland hospitals, we've had some effect, but nothing like you're hearing in some of the other places in the country. Our non-Maryland hospitals, we have our old children's in Florida and Sibley in Washington, D.C. They've had more of an impact because they're not in this payment system. And the largest impact has been on the school medicine and the practice plan because they are still on a fee-for-service. And because we did stop our elective surgery and our outpatient services, they have had a fairly large substantial hit. The health system is helping the school because they have had less of a hit. But I think both for the last 3 months of fiscal 20 and the first at least 3 or 4 months of fiscal 21, the school will have a large financial hit.
That's a difficult question.
No, it's not a bad question. And someone asked, I saw that about the CARES Act. We did get revenue. Again, because of our Maryland payment system, the CARES Act had less of an impact on Maryland hospitals, but both Sibley and Old Children's and the practice plan did get money out of the CARES Act to help.
Great, thank you. Lisa, what is the natural history of this virus as an infectious agent?
So this is a complex topic, actually, because the virus can cause such a wide range of types of illnesses. So we know that some patients contract the virus and remain asymptomatic. Some have very mild self-limited illness. The vast majority can recover at home, and although even those who don't require hospitalization, we know that it can create very severe symptoms. And one of the unique features that I would say that comes to mind in terms of natural history is that it seems to last longer in some patients, much longer than we typically think of the respiratory virus sort of running its course within 10 days, and can have a paradoxical worsening after day 10 or 11. So we have had patients who stay at home for the first 10 days, have an initial phase of recovery, and then worsen. And some of them require hospitalization. So it's really all over the map. That's probably a whole nother talk. But we are learning so much about the virus. And in addition to respiratory symptoms, really every organ system seems to have some involvement, potential involvement, clotting disorders, effects on the heart, neurologic effects, and other things. And of course, one thing that I would point out that we have learned is the wide age range that is affected. And so contrary to some of the early reports that talked about primarily the elderly population and those with comorbidities, that we have seen many patients in their 20s, 30s, 40s, and 50s admitted to our hospitals. And now, of course, the inflammatory condition in children is of concern. So that's a complex topic, and there's a wide variety of manifestations.
Roy, I have a question. Thank you so much, Lisa. Question for Roy, and I don't know if anyone knows the answer to this, but what will the fall look like for the different types of students?
So that's a great question. Of course, no one knows the answer, but I think a safe answer is it will be very different. I think that probably the question is focused more on medical students than on graduate students and others. Very briefly, we're certainly hoping that graduate students will be able to get back in the lab sometime soon and stay in the lab. There are graduate students in the lab right now, but they're the ones that are doing so-called essential research that is generally focused on COVID-19. For medical students, it will look different. I think most of the people in the audience remember the experience, for better or for worse, at the anatomy table. Perhaps many of you remember it as a very positive experience where you bonded with your classmates and you really understood the sanctity of human life in a very powerful way. That's going to be very different. We actually are a school that continues to do cadaveric dissection. Many schools have abandoned that a while ago. We will still do cadaveric dissection, at least that's our plan in the fall, but it will be different because there needs to be de-densification of the anatomy lab space. And so we will almost certainly be going to prosection rather than dissection. And we will be having the students coming in shifts rather than at one time. They'll be rotating around the anatomy tables. They'll be de-densified and socially distanced and of course masked and so forth. So it's going to be very different. Much of our curriculum already remember this began in mid-March. Much of our curriculum for the end of March and April was already transitioned to online. And that transition for the fall curriculum will continue. It requires a lot of work for our faculty, but again, I think you'd be unbelievably proud of our faculty have done an amazing job. Again, really, I think participating in a revolution. So it will be very different. For the third and fourth year students, we're really hoping that the fall will be similar to the way that it is now, with direct patient contact as permitted, with all of the usual precautions. However, the fourth year students, their involvement with residency interviews and so forth will be very, very different from what most of our experience was. Many of us did away electives, so-called audition electives, and those are essentially gone across the United States for the most part. And interviews will not be in person, they'll be virtual. And so we are now charged with helping them to develop the skills of interviewing in a virtual environment. It can be very different. And frankly, we're trying to develop our faculty to interview students for residency programs virtually. It's very different. I don't know if any of us come across well to you here by Zoom, but I wouldn't want to be judged right now for residency based on how I'm coming across to you.
Okay, yeah. So Lisa, thank you, Roy. When do you expect the second surge?
So no one knows for sure, but we do have experts in modeling, infectious disease modeling, that provide us with their data-driven models. And I think that, and it of course depends upon our own community's behaviors and policies and response, especially as we start to see changes in the number of patients in any given area. But right now, what I would say is that we do anticipate a second surge, as I said earlier, to come in response to the reopening and the decreased social distancing. I believe that it takes between 6 and 8 weeks before you see at a population level the effects of any major changes. We had really maximum social distancing and staying at home in early April. And I believe that now we are reaping the benefits of that by seeing the plateau and the decrease in the Maryland area, at least, from that social distancing. So I would say that in the late June, July, we are likely to see increases. And then depending on what we do in the coming days and weeks, that could extend into the fall as well and mix with flu and other respiratory viruses.
Thank you. What is the latest on vaccines for COVID?
So I can take that. There are about 100 vaccines being developed around the world. The modalities vary from the Moderna RNA vaccine and DNA vaccines and peptide vaccines to attenuated viruses to subunit vaccines in which parts of SARS-CoV-2 have been put in other viruses. There are 4 being put forward in China that are fairly advanced and 4 here in the US that are fairly advanced. They are being, those 8 are in human trials right now, mostly safety trials initially. The timing of when the vaccine may be produced is very complex because we don't really know how the safety trials will come out, nor the efficacy trials. We know that the federal government and some of these companies are already producing some of these viruses in mass quantities, just in anticipation that they'll work. So, you know, they are speeding a timeline for vaccine production as fast as they can, but I don't think anyone can give you a date now when it'll come out.
Thank you. Besides the face shields, has Hopkins developed new types of PPE, for example, N95 type masks? And can you tell us about them if there are any?
Yeah, so we have not developed N95 respirators. Those have to fit so tightly and so perfectly to get a seal that it's very difficult, although we did try. But what we have done instead is focus on obtaining reusable respirators, including powered air purifying respirators or PAPRs, and some half-face mask respirators called Dragers. Our colleagues at the Applied Physics Lab have invented, created, and manufactured some hoods for use with our PAPRs and helped us to 3D print the connectors so that we can use them with the various types of PAPR respirators that we have. And we have obtained reusable gowns are in short supply as well, the isolation gowns. And the Ford Motor Company is one place that we've obtained these. So there's really been an across the board effort on PPE.
Oh, this is a great question for everyone. Can alumni help prepare students with their virtual interviews through mock sessions?
I'll take that. I think that's a great idea. You know, alumni have been incredibly helpful to our students over the years in a variety of different ways. And I think that this could be one of them. I will work with our Alumni Association and take advantage of that question. So thank you.
I'll sign up. Okay, last question here. Let's see. Lisa, what is the standard of care for post-hospitalization COVID infection patients? Is there a good reference for clinicians to refer to?
Well, again, that's a very variable question depending on the patient's clinical course. As Paul mentioned earlier in the webinar, we have a convention center, field hospital that is set up that is helping us discharge patients who are not yet ready to go home, but who still need care. And we are also looking at ways to care for those patients who still need mechanical ventilation. So those who might need chronic ventilator support. But the vast majority of patients who recover can be discharged back to home, thankfully.
Thank you so much. And thank you everyone for joining us here. I now turn it over to Dean Rothman.
Great, thanks. Diane. First of all, I'd like to apologize. We couldn't get to everyone's questions. There are a lot of good questions, but we could go on for an hour. And if you do have other questions, you can email Lisa or I or Roy. We'd be happy to answer them the best we can. I wanted to thank our panelists, Lisa and Roy and Diane. Thanks for spending the time with us today. And thank you, first of all, for all of you who take care of patients. We know how difficult a time this is. And for those of you for joining us today on this virtual reunion. I want to remind everyone at 4 o'clock, we have our crab cake cooking demonstration online. And then this evening, you'll be with your classes. So again, thanks everyone for joining us today, and please stay safe.
Thank you.